Hello everyone and welcome. A big thank you to Dr. Avila and the rest of the planning committee for inviting me to give this talk. I will be speaking to you on foot and ankle pathology with some ultrasound correlates. I'm Ashwin Babu and thank you so much for having me. I do not have any financial disclosures that are relevant for this talk. In terms of the learning objectives, what we're going to do first is start with some introductions, tell you a little bit about who I am and why you're bothering to listen to me. Then we'll talk a little bit about differentiating normal tendons from tenosynovitis versus tendinosis using ultrasound. We'll differentiate normal ligaments versus low versus high-grade tears. We'll talk a little bit about tendon snapping and ligamentous instability, and again, how we use ultrasound and typically dynamic sonography to help identify these cases. We'll look even for occult fractures using both direct and indirect sonographic signs. So first and foremost, a little bit about me. So I'm Ashwin Babu. I did a lot of my early training in New Jersey in the United States at the Rutgers University. I did my undergraduate and medical school both at Rutgers as part of a combined degree program. After medical school, I moved to Chicago, where I attended Northwestern University's rehabilitation residency program. At the time, it was called the Rehab Institute of Chicago. It's now what most of us know as the Shirley Ryan Ability Lab. After that, I moved east to Boston and completed Harvard and Spalding's Sports Medicine Fellowship. After that, I got hired on and stayed working mostly clinically at Massachusetts General Hospital as part of the Sports Medicine Service. In terms of my overall care these days, I take care of many athletes using non-operative sports medicine care, a lot of ultrasound-guided diagnostic and injection procedures. I also have the opportunity to take care of the Boston Bruins, the local hockey team, the New England Revolution, the local soccer team, and I'm also part of a network of physicians that helps to care for the United States Paralympic soccer team. One of the things I love most of all these things, however, is learning and teaching ultrasound. So that's what we're going to go through a little bit more today. We're going to start by talking about tenosynovitis. And in order to do this, we're first going to use the tibialis anterior as our first example. Interestingly enough, the tibialis anterior is not the most common structure that we typically think of when we're talking about dynamic sonography. Here you see a classic anterior view of the anterior ankle with the tibialis anterior. You can see my pointer here with the tibialis anterior identified here. Most commonly, when we talk about tenosynovitis, we're typically referring actually to the outside of the ankle, or the peroneus or fibularis longus or brevis, or on the inside of the ankle, the tibialis posterior. Classically, this is because there's a pulley effect across the medial malleolus. Tibialis anterior tenosynovitis is much less common, although that's what we have a good example of today, so we're going to show that. Whenever you see tenosynovitis, wherever it is, classically you'll expect to see a circumferential halo surrounding the structure of interest, and that's really some hypoechoic fluid. You can get fluid not only in the tendon sheath, but around it as well, so you can see kind of peri and intratendinous fluid. So here, I've zoomed in this picture here just to be a little clear. This really is fluid you can see inside the tendon sheath. Contrast that to this picture here, where there's fluid outside of the tendon sheath as well. So when you have true tenosynovitis, you can actually get both. These markers here indicate that fluid outside of the sheath. Whenever you get tenosynovitis, something you can also get is neovascularization or hyperemia, and would see that with the use of Doppler imaging. And you can see the little Doppler signal here, outside of where you see that hypoechoic fluid. Another thing that's important is whenever you look for tenosynovitis and you're looking at really any structure, you need to look at two planes. So I first showed you a typical cross-section view. Now let me show you what tenosynovitis looks like in long axis. You'll notice a few things here. First, these arrows denote the classical pattern of the tibialis anterior, nice tight fibular pattern as we'd expect to see. These markers here show some fluid above the tendon sheath. And again, the Doppler indicating some hyperemia in the area. So those same principles you can see both in short and in long axis. When we talk less about tenosynovitis, but instead we're talking more about degenerative tear, like tendinosis or partial tears, one of the most common examples we think of is the Achilles tendon. When you look for the Achilles tendon, usually the patient will be lying prone. You will be using a nice in-plane transducer angle looking along the long axis of the Achilles tendon. This is an MRI correlate that you see here, a T1 weighted image showing the nice dark black tendon as we'd expect it to see. Remember that when you see tendinopathy, it tends to be in the mid-substance. The pathology here is quite interesting. You really aren't having a true inflammatory issue. Really, it's more mucoid degeneration. You notice over times with repeated injury, there'll be less and less of the typical parallel fiber pattern, and instead you'll get neovascularization, so those new blood vessels growing in. You'll have an increase in the type 3 to type 1 collagen ratio. You'll have cell apoptosis. So in general, a lot of disorganization of the tissue. In the Achilles, when you find this, it usually is, like I said, in the mid-substance, somewhere between 2 to centimeters proximal to its insertion of the calcaneus. The classic sonographic findings that you'd expect to see is what we call fusiform thickening, meaning swelling along the axis of the tendon, not just one focal area. You'll also see hypoechogenicity, or dark areas in the tendon when looking with ultrasound. You can sometimes see some calcification changes, that same hyperemia like we talked about before, and some hypoechoic signal in the tendon itself consistent with some interstitial or partial tearing. You can also get enthesopathy, which is really irritation of the tendon more at its enthesis, right where the tendon inserts into the bone. This is that hypovascularized zone I was telling you about. On ultrasound, what we classically see is a picture like this. The first thing we notice here is how thick this Achilles tendon is, and it has that fusiform swelling. Secondly, this green little box here is the Doppler box, and notice all the hyperemia and the Doppler signal in the tendon, all indicating a much more substantial degenerative process. Now, we talked about tendinosis. What about tears? So whenever we look for a tendon, this is the normal view of a classic long axis Achilles tendon. And what we have here is what's called an extended field of view. And so, this is one image that the transducers have been slide, and many images have been taken together and stitched together to form one long image. This is the typical pattern and the thickness that we'd expect for the Achilles tendon. Contrast that with this image below. We see several interesting things. First and foremost, and most importantly and obvious, is the thickening of the tendon in this area, considerably thicker than the image you see above. Secondly, we see some of these calcifications in the mid-substance of the tendon. Notice a sharp hyperechoic border with deep acoustic shadowing, meaning darkness below, implying that this structure is very dense, in this case, very likely to be a calcification.
Now let's look at what partial and full thickness tears look like on ultrasound. So here we have a longitudinal view of the Achilles tendon, and the patient is being passively plantar and dorsiflexed. This is the proximal edge, this is the distal edge. You'll notice that when the patient is moved into that dorsiflexion, it puts more tension across the Achilles tendon, and you can see the tension going from both the proximal and distal ends. There is, however, a hypoechoic region in the middle, very consistent with a partial thickness injury. These images come from the Jacobson textbook. Contrast this with the image on the right here. This is the same kind of setup where a patient is passively dorsi and plantar flexed, proximal on the left, distal on the right. As this moves, now, however, you notice how this hypoechoic region is much larger, and the ends appear to move freely, indicating that there really isn't any connection between the two. Therefore, this is much more consistent with a full thickness Achilles rupture.
Now, that's in terms of tendon injuries. Now, let's move our attention to ligamentous injuries. And the classic example we think of for ligamentous injuries around the ankle is with the lateral ankle complex. Lateral ankle sprains are by far the most common injury that I'll see in a typical sports medicine clinic, particularly where I see a lot of soccer athletes. When you talk about ankle injuries, ligamentous injuries, we usually are referring to several very important ankle ligaments, most important of which is the ATFL, or the anterior talofibular ligament. Remembering that the ATFL actually has two distinct bands. It has a superficial and a deep band, which attach adjacent to each other. When looking at these images, you typically want to be long axis to the tendon, so you want to see its fibular and its talar attachments, and you see a nice tight fibular band with a slight thickening in this area. Likely, this is a grade 1 type injury. Now here we see a normal ATFL, and we see some dark fluid below this. So this is a normal kind of picture with maybe a little effusion in the ankle. When you injure these tendons, it's usually with inversion and plantar flexion, both of which stretch the ATFL. A grade 1 really is that stretching type injury without disruption or instability. Grade 2 is when you actually have a full partial thickness tearing, meaning the tendon is not completely torn, but most of the fibers are injured. Grade 3, of course, being a full thickness tear. When you have these injuries, it's classically the ATFL that's injured all by itself. It's about 70% of cases. You can get more severe injuries involving the CFL, or the calcaneofibular ligament, and the posterior tibiofibular ligament, which is really quite rare. And isolated injuries to the CFL and the PTFL really very uncommonly happen. Most of the time when you're getting an isolated injury, it's the ATFL. So like I said, here's that normal injury here. We're looking for when you see a typical grade 1 injury, compare these two together. Notice how thicker this ATFL is in more diffuse area. That's classic for a stretch type injury or a grade 1 injury. Grade 2 injuries are when you have these kind of diffuse thickening, but you have disruption of actual fibers, which will typically manifest as actual hypoechoic regions in the tendon, and you can see very similar to what we saw with Achilles, but on a much smaller scale. Higher grade injuries, however, you can notice some MRI correlates. So in particular here, we have a T2 weighted axial image of an ankle. And this is the talus, this is the fibula. You'd expect the ATFL to cross the border here. However, when we zoom in, we can see it's quite difficult to follow fibers from the tibia, from the talus to the fibula, And these are the retracted ends of that ATFL. So this is a full thickness injury.
So here we have an ultrasound correlate to that MRI finding. So here we see, like I mentioned, the retracted ends of that ATFL tendon. And here we see the ultrasound correlate. And so here is the fibula, here is the talus. And in the same way we have a hard time following fibers from one end to the other on the MRI, we have a hard time following these fibers here on the ultrasound. Instead of a tight fibular pattern that we'd expect to see, instead there's this kind of almost mushy, heterogeneous tissue that's not very consistent with intact fibers. We also see a lot of edema in the surrounding tissue, which I'll talk about momentarily.
We have an injury like this, a common question is why on earth is there so much fluid there? And here's what I'm referring to. All of this hypoechoic fluid, all the hypoechoic structure here is fluid that's leaked out from inside the joint up into the area. And basically what happens is when you have this lateral ankle injury, you really are rupturing the capsule of the ankle. And so all the fluid inside the joint, and typically when you tear some veins, some arteries that I'm going to show you in a moment, you can get lots of bleeding in that area. So here's an anatomic diagram here, and unfortunately it looks like my head might be in the way a little bit here. This is the fibula, this is the talus. Here are the two bands of the ATFL, and the point really that I want to make here is that this blood vessel courses right along where the ATFL is. So you can imagine if you get a rupture of this ligament, you can also get tearing of this artery, and that can cause all that hemorrhage that we talked about before. This is the anterolateral malleolar artery. So we've talked about tendinous injuries in the Achilles. We've talked about ligamentous injuries with the fibula, with the ATFL. Now we're going to talk about instability. For tendinous instability, the classic example that we'll use is the peroneal tendons in the lateral ankle. The fibularis tendon can be unstable in a couple classic ways. A type 1 type injury is usually when you have an injury to the superficial peroneal retinaculum. You'll get diffuse hypoechoic thickening of the area, and what will happen basically is that a little pouch will be created because the retinaculum will peel off slightly. And so that's what we see here. This is the superficial peroneal retinaculum, and instead of it being nice and tacked down to the bone right here on the fibula, there's this little gap here that was created because the tendon peeled off. Into that gap is sitting the peroneus brevis tendon. I'm just going to play a video here. And as this is motion of these peroneal tendons, and you can see them subluxating into a pouch created by an injury to that retinaculum. So this is a classic grade 1 injury, or type 1 injury, excuse me. A type 2 injury, however, is when that retinaculum doesn't just peel off a little bit, but it fully tears off the bone. And at this point, the peroneus brevis and longus tendons can actually subluxate out of their typical position, superficial to the fibula. And this can be associated with a sensation of instability or snapping by the patient. Here's what that classically would look like. This is that thickened superficial peroneal retinaculum. Here is the fibula, and instead of sitting in its typical location, in the retromalleolar area, they have now subluxated superficially, so the peroneus brevis sits on top of the fibula, as does the peroneus longus. Here is a video demonstrating that full thickness injury and the full subluxation of that peroneus brevis tendon. Notice how, as the video loops again, it slides all the way over and is now sitting superficial to the fibula. A type 3 injury is when you have basically that same type 1 injury where you have a peeling or sometimes a full thickness injury, but the main difference here is that you actually take a little piece of bone with it. Notice that in this diagram here, this shows a little piece of bone that is avulsed off of the lateral malleolus, and that is classic for this tendon instability. So here's that same kind of picture. You see the peroneus brevis, the peroneus longus, you see the superficial peroneal retinaculum. The only big difference here is, notice a hyperechoic structure here with shadowing deep to it, suggestive of an avulsion fracture. Now, before I leave you thinking that the tendons can only snap over the top, another thing that they can do is subluxate in the sheath themselves. So intra-sheath subluxation is something else that can happen, and here's what that classically looks like. This is with a patient actively circumducting their ankle. You can see the peroneus brevis typically stay in its medial position and then subluxate and snap outside or further lateral and posterior to the peroneus longus. Most of the time, these injuries are asymptomatic and you get to leave most of them alone. However, sometimes they will need to be more aggressive treatment. When you find these, it's usually associated with a convex as opposed to a concave posterior fibular contour, a low-lying fibularis brevis, or a fibularis quartus muscle, all of which puts extra pressure in this region. With repeated snapping, you worry that more tendinosis and tearing can happen. So if that is a possibility, you get a little more worried and are more likely to treat it either with a lace-up ankle brace. In very rare circumstances, we'll think of things like steroid injections, although for the most part, we try very much to keep steroid away from weight-bearing tendons. We're going to wrap up here by talking about occult fractures and how we can find some of these fractures with ultrasound instead of the classic modalities such as x-rays or MRIs. And more likely, I'll show you how the ultrasound really acts like an adjunct to those other modalities I just mentioned. So the first case we're going to discuss here is a patient who has a proximal fifth metatarsal pain after an inversion ankle injury. So they rolled their ankle, they felt a lot of pain on the inside. So the first thing that's most common to do in a sports medicine clinic in this case is to order some x-rays. Here you see a lateral, and we're just going to flip that around so it looks more analogous to what we're going to see shortly with ultrasound. And what you'll notice here really is a pretty normal looking x-ray. I don't see any obvious signs of an injury to the base of the fifth on these images, nor to any of the bones of the midfoot. Now, when we look with ultrasound, what we notice here is the nice hyperechoic pattern of the base of the fifth metatarsal, and then there's a little area which looks quite abnormal. This is a cortical irregularity or a step off, and whenever we see that, that's a direct sign of an injury to the bone. Notice there's also a little hypoechoic signal around it, suggesting some surrounding edema. Again, this is that analogous picture on the x-ray. I really don't see much on the x-ray here, but that ultrasound is really quite clear. This is kind of an occult fracture of the base of the fifth that was not picked up on x-ray, but ultrasound led us to the correct diagnosis. The next patient that we're going to talk about here is a 35-year-old male rock climber. He falls about 10 feet while climbing, and he has lots of ankle swelling afterwards. Again, because of the acute trauma to the injury, we'll start with some x-rays. So we get a classic AP x-ray, a classic midfoot x-ray, and then a lateral. And what we're looking at all these pictures is any obvious signs of a fracture or major injury. And I don't really see much here on these images. This is a pretty healthy looking ankle from these perspectives. So then we use the ultrasound machine. On ultrasound, we look in the long axis view, and we see the talus, we see the distal tibia, and this hypoechoic signal here is the cartilage, or the true tibio-talar ankle joint. One area of the cartilage looks nice and normal here, but as you move further medially, you see increased hypoechoic signal here, consistent with an ankle effusion. And so when there's an acute ankle effusion after a fall or a trauma like this, it makes us a little more suspicious that there's something wrong in the joint itself. As this video plays, notice how normal the cartilage looks here, and then as you move more laterally, we notice some increased hypoechoic signal. We also see, if we look very closely, in this area where the hypoechoic signal is, we see some bony contour change to another area of the talus. So more suggestions that there's something going on in the joint itself. Here's this same patient. You see the talar neck, the talar head, and a large effusion that's pocketing a little more laterally. When we get an MRI, we see basically the same thing. Here is that nice kind of hypo, on the T2 weighted image, quite bright, but on ultrasound quite dark, pocket of fluid that we see sitting near the talar head and the talar neck. And so this is the analogous MRI and ultrasound correlate. And what you're basically seeing here is an effusion in the ankle joint. Remember that one slice I showed you where the bone didn't look so good? This now needs a little bit more evaluation. When you move slightly laterally on the MRI, all of a sudden we see the same correlate that we saw on ultrasound, which is an area of cortical irregularity, this time in the talar dome. So this here is an injury, an osteochondral injury to the talus after an acute injury that really is only picked up by the ultrasound or the MRI. The x-ray really didn't tell us the picture there. We're going to, one more case here about a 57-year-old female who fell off her bike and afterwards noted a lot of dorsal midfoot pain. Again, we got x-rays and really no obvious fracture or major problem is noted on these images. So we break out the ultrasound machine, and this is what we'd expect to see for a classic second metatarsal. And of note, this is where she's point tender. We really see not much going on here. However, when you look with ultrasound, what we see is quite a different story. Here you'll see a nice bright cortical border with shadowing deep. We see the same kind of thing, except there's one area right here that looks quite abnormal. A hyperechoic structure, no shadowing deep to it, but lots of surrounding edema. This should make us quite concerned for an injury to the bone itself. One of the most common indirect signs of a fracture is adjacent effusion, periosteal edema or stripping of the periosteum, which is what we're seeing here, soft tissue edema or hyperemia, and that's all this dark structure here, all that hypoechoic signal. All secondary signs or indirect signs of a fracture. Remember, one view is no view, so we look at the same structure in an orthogonal plane. So here we have that same third metatarsal. We see lots of fluid and hemorrhage surrounding this area. And here's that area of cortical irregularity that we notice when viewed in cross-section. So now we're seeing the same problem, but in two orthogonal planes. We have to be very suspicious that there's an injury. Fortunately, we have an MRI correlate here. And so here's a view of that third metatarsal. Notice, remember the picture that I showed you before, hyperechoic with a little periosteal stripping. We see the exact same thing here on the MRI. The only thing that the MRI does tell us that ultrasound does not, by the way, is the edema in the bone itself, which is very significant, which is very suggestive of a fracture here. Excuse me. So here we have indirect signs of a fracture. That orthogonal view, by the way, we see the exact same thing. Here's that view we saw before with the hypoechoic fluid suggestive of edema, and look at the MRI correlate. Look how bright the metatarsal is. So clearly there's a lot of injury in the bone, and all of this surrounding edema and hemorrhage suggestive that there is a bone injury here. So with that, I'm going to wrap up the talk here. Thank you all so much for your attention. A big couple of thank yous. First to Dr. Kingsbury and Gellhorn, who put original versions of this talk together. A big thank you to Dr. Avila and the rest of the program planning committee for inviting me. I just wanted to leave you with these two textbooks that I find particularly helpful. The first, the John Jacobson Fundamentals of Musculoskeletal Ultrasound text, which I get a lot of the videos from the online material and I use quite commonly to help with education for ultrasound. And the second is Anatomy is really the key to all ultrasound teaching, and so Netter's Concise Orthopedic Anatomy I found to be an excellent resource. I'll gladly take any questions. Thank you all so much for having me.